On this episode of the ASC Podcast with John Goehle, we discuss the latest coronavirus news, recent OSHA fines for N95 masking, and in our focus segment, Daren Smith of SIS joins the ASC Podcast to discuss how COVID-19 affected ASC operations and motivated surgery centers to invest in and consider new solutions and software that can help them tackle the challenges of today and capitalize on the opportunities of tomorrow.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, SIS. SIS's mission is to deliver solutions and services that help surgery providers, regardless of care setting, improve their organization so they can deliver the highest level of care to their patients. For more information, go to sisfirst.com.
Welcome to episode 137 of the ASC Podcast with John Goehle for August 16th, 2021. Recording from our studios in Spencerport, New York, this is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies. He is recognized as one of the nation's leading experts in the ambulatory surgery industry. John is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory accreditation and finance issues.
So it's been a while since you've heard from us out there. We were on vacation for a while, and of course, we've been busy with various conferences. We just finished the Infection Control Conference a couple of weeks ago, and we're going into the ASC Administrators Bootcamp, which is this week. This recording will probably come out after the first day of that conference, so we're very excited about all the conferences we've been doing and the great feedback we've been getting from it. Also, Sue and I are recording, I keep saying that from our new studios, but it's just...
We have upgraded yet again.
We have upgraded yet again. This is ASCP Studios version 3.0. So now we have new lighting, which is kind of annoying. So we're looking at the monitor up there, and it's right in the way of the lights. So it's we're actually doing we're testing all the equipment out before tomorrow's conference. So we're actually doing video, which we normally don't do. We won't post it for anybody, but it is kind of interesting to get used to this new equipment. But thanks to all of the patron members who have helped to finance the massive infusion of new equipment that we've had to do in order to meet the demands of our studio for the conferences as well as the podcast.
It does seem like we're finding more and more things that we need to talk about that we between the conferences, the boot camps, and the podcast. So it's really... I remember way at the beginning, and I know we've mentioned this before, it's like, how could we have something to talk about even once a month? And it just... we just keep finding things that we can help educate people on. And
we get such great feedback from our patron members who join us on Saturday mornings as well as the boot camp, and we really appreciate that. And again, anybody can give us feedback by sending an email to comments@ascpodcast.com. We take everything seriously, and if you have something that you'd like to learn more about, feel free to do that. Sue, we also haven't posted an episode of the staff edition in a couple months, so we're going to have to do that. We're struggling to keep up with, the demands of everything. The Ambulatory Healthcare Strategies has grown so dramatically in the last couple months. As we take on more and more facilities, we're bringing 3 new facilities on board within the next 2 weeks, and we've expanded into New Jersey. So anybody that's in New Jersey and is looking for regulatory consulting, we've hit the ground running in that state right now. So we're very excited about that opportunity. We already dominate. Ambulatory Healthcare Strategies really dominates New York State. I think about 25% of the facilities in New York are clients of ours. So, but that has kept us busy, and we apologize that we haven't had much of an opportunity to do these podcasts. So we'll try to pick up on that. Again, talking about the patron members, Sue, we really enjoy our Saturday morning sessions, and any patron member can avail themselves of that Saturday session. We have great conversations on Saturday. So for more information about becoming a patron, visit ascpodcast.com. But please remember, the podcast itself is always going to be free. And the patron program just provides additional benefits and discounts. And we just announced the next director Director of Nursing Bootcamp, which sold out in May. The next one will be November 16th through the 19th, 2021. We're calling it the Director of Nursing Bootcamp November Cohort. And we are going to have another Administrators Bootcamp. Of course, the August cohort starts this week, depending upon when you're listening to this, in August.
Tomorrow for us. Yeah.
Tomorrow for us. The next ASC Administrators Bootcamp is going to be in January of 2022. Can you believe that, Sue? It's only 4 months away.
I know.
January of 2022. So we're going to be doing at least 4 boot camps a year now because of the huge demand for this. And already we have over 50 graduates of the boot camps that we've done so far. And by Friday, we'll have another 25, 26, I think we have. And we're just so proud of all the effort that these individuals have put into these boot camps. And it's a great pleasure to produce them.
And every time we do one, it seems like we come away with another idea for either a full boot camp or a day-long education that people, need a little more in-depth on. So and keeps growing.
And from the Administrators Bootcamp, both from the Administrators Bootcamp in January and the Director of Nursing Bootcamp in May, we got a lot of feedback about the walkthrough. There's a section of both of those bootcamps where we walk through the conditions for coverage. And we do it in 4 hours, and it seems like a lot of time, but when we get into it, we're always really rushed for time.
Yeah, and they're so important.
They are. So we have decided, and again, with feedback from our patrons, that we are going to, in December, have a full day walk through the conditions for coverage and interpretive guidelines. So I'll be announcing that very shortly as soon as I can get the graphics and the advertising all together for that. So again, if you're an Ambulatory Healthcare Strategies client, you always get those types of conferences for free. And if you are not, of course, we'll make it available at a very reasonable price. So we got so many things going on. You need to visit ascpodcast.com frequently, and of course, listen to the podcast here. Stu, I've been out and talking to a lot of clients lately, and I'm constantly saying, hey, did you listen to the last podcast? And what I realize is that people are so strained for time right now that, they're lucky if they get to listen to the podcast, within 2 weeks afterwards. So we do know that, and we'll try to be a little more timely about getting them out, even if they're shorter, I think. What ends up happening is when we wait a month, we end up with a very long podcast, and I know that's frustrating trying to listen to that. So we have a lot of news. We're going to break the news up in the next couple episodes, but we'll talk today about the most pertinent stuff. So Sue, why don't you kind of introduce a couple topics?
From OR Manager's August 11th, 2021 edition, a study was conducted by researchers at the University of Birmingham in England that indicated the patients who had isolated pre-surgery to avoid COVID actually had an increased risk of postoperative pulmonary complications. Now, of course, not getting COVID is the most important thing. But I just found this interesting. They said after adjusting for age, comorbidities, and this part I'm quoting right from the article, and type of surgery, patients who isolated preoperatively had a 20% higher risk of postoperative lung complications than those who didn't isolate. The risk rose if patients isolated for more than 3 days. Isolation from 4 to 7 days was associated with a 25% increased risk, and isolation for 8 days or longer with a 31% increased risk.
So, Sue, my question is, this seems counterintuitive, doesn't it? That, don't you want to have people isolate before the procedure? Why is this proven to be not great? Yeah,
it seems strange, especially for me because it was such a short amount of time. But what they found is that it's associated, if you're isolating, you're probably decreasing your physical activity. Oh. You may be eating worse. You're just sitting home munching all day. Higher levels of anxiety and depression. And so this can result in contributing to an increased risk of these pulmonary complications. Now, I think, obviously you still want people to isolate, but the takeaway, maybe the doctors or whoever's getting the patients ready can just kind of remind them, walk around your house. Yeah. Maybe you're not isolating, but also even on a bigger scale, this is kind of what all of us are doing right now. Yeah, just on a grand scale. So, you think of how this must be affecting everybody's health because this is kind of this. I mean, they talk about 4 to 7 days. Yeah. How about a year?
Well, it was a long walk for us from the kitchen down here in order to do this recording. I guess the only good news about it is that we had to go up and down the stairs to do it. But you're right, is that we're not getting into a car, or we're not going somewhere. We're not walking into the place. You're doing that once. So you're not getting that exercise. This does make sense.
But even for, you and your family, like my mom is going to look into having her second knee surgery done. And I think, you have to remind her, hey, walk around your house. Maybe you're not getting out, but try to still do the things you would have been doing. Don't lose that strength. And there was some OSHA news, and I know, John, you're always talking about this, these OSHA fines. So a Lakewood, New Jersey medical facility and a temporary staffing agency were fined by OSHA for failure to ensure the safety and health of nurses who were giving flu shots and testing patients for coronavirus. The investigation was triggered by a complaint and found that the company required workers to wear respirators but did not do the required medical evaluation or fit testing. So OSHA cited the facility for 2 willful violations and proposed a fine over $270,000. The temporary staffing agency was cited for 2 violations, and they proposed a fine of over $13,000 for them. The employers have 15 days to respond or contest the findings. So you can find more information on the requirements by going to OSHA.gov/coronavirus/ETS. So, you've said that they're high fines, and that really was. And it would be, I'm sure they probably had good intentions getting them N95, but they didn't do that fit testing.
They didn't follow the rules. And not, the fit testing, the respiratory protection program, and if I remember right, a big issue that came out of this too was that they didn't do the medical evaluation.
Yes.
And what they actually said, what OSHA actually said, is that they endangered the life of the patients, or the employees in this case, by not properly evaluating what risk they would have by wearing those respirators long term.
Yeah. And it was a complaint. So really, anybody who feels that they're not being kept safe, and a lot of people right now are a little disgruntled. Yeah. Just because of all that's going on in the world. So you really have to protect yourself and protect your employees.
I'm not aware yet that an ASC has yet been surveyed or tagged or fined. We'll keep a very close eye on that, because I suspect it won't be long. And we know the hospitals have been doing it, but this was the first time we had something that we saw evidence of something that came close to what we're doing, and very specifically about N95 masks. And one thing that I have found is I have talked to people. We've been enforcing it on our clients, from the very beginning. But, when I do surveys, and when we're talking to potential new clients, or when we're just talking to, members of various associations, that unfortunately this failure to do the fit testing and the respiratory protection program is not uncommon. So I think we have to be very careful. If you haven't done it yet, yes, you're going to be in trouble, but you're going to be a lot more trouble if you don't identify the problem and fix it right away. And just remember, as Sue said, this could happen simply because somebody complains to OSHA, and there could be a long tail on that. In other words, they might send a complaint in now, and they might not come out for many months before they actually do it. So, and you might already be in a situation where employees or ex-employees have already complained to OSHA, and they're just waiting to come out and see you when they have time to do it. So, just because you haven't had it happen yet doesn't mean that you're safe. I don't know how many other times we can say this, or how many other ways we can say it. If you got an N95 mask, you got to follow the rules. And, Sue, while we're on the topic, I know we've said this many times before. If you are doing a procedure in the procedure room or in the surgery suite, and the N95 mask is the only mask that's facing the patient, that mask has to be replaced after the procedure. You could put a mask over it and then throw that mask that you put over it out. But there are concerns on the part of ALRN and some of the mask manufacturers that putting a mask over an N95 invalidates the effectiveness of that program, which means you're not following the manufacturer's instructions.
Yeah, so you have to check those, because if that says not to, then you can't do that.
And what's the rule again about manufacturer's instructions? We have to follow the manufacturer's instructions. Yeah. Let's talk about some recent experiences. A number of our surveys recently, we've had some very, very good surveys lately, and some of the surveyors have been shall we say, struggling a bit to find something to at least write up. And this has not resulted in a citation, but there has been consultative comments coming out about the use of the term MAC anesthesia, in other words, monitored anesthesia care. So apparently the Anesthesia Association has gone on record of saying that when you're using terminology in your consent or in the operating room records or on your records, you need to be more specific about the type of anesthesia you're providing, and that MAC is a very general term that's used largely for billing purposes, and that what you really need to be including in your consent with the patient and in your records is more description of what the anesthesia is that you're using, such as minimal sedation, moderate sedation, or deep sedation. So we are encouraging all of our clients to start moving in that direction, be a little more descriptive in that. Again, we haven't been cited yet for this, but we have had consultative comments about the use of that term.
And we just wanted to mention making sure that you have SDS sheets for all of your drugs, in addition to any cleaning chemicals or other chemicals that you may have on site. A lot of people forget the medication part of it.
Yeah, and that came from our dear friend George Scoris, who's a pharmacy consultant in New York State. I think he's also in New Jersey. But he pointed this out to us, and so we're continuing to monitor that with our clients. So we thought that would be a good thing to kind of mention here is that your SDS sheets need to be comprehensive. And I'm assuming everybody knows what an SDS sheet is, but it's a safety data sheet that applies to any chemicals or products that might prove harmful to individuals. So, and certainly drugs falls into that category.
And they can change over time. But if you've had a certain medication you've been using forever, recheck the manufacturer's website and make sure you've got the most current.
So, unfortunately, we do have to talk about COVID. I know for a very long time that's all we talked about. Then we've been trying to get a little bit away from it, but there are some actions going on right now that we kind of have to mention again. Many states are starting to crack down on vaccine, or at least implement some form of vaccine mandate, following in the footsteps of what's happening in California. California is requiring it for all healthcare workers either to be vaccinated, or if not vaccinated, they have to be tested at least weekly. We are closely monitoring, as we go to press today, New York, New Jersey, and Pennsylvania announced mandates also. Unfortunately, there's no details yet. The regulations themselves were not posted as of the time that we went to press here.
We're hoping and assuming that they'll require that you just can be tested weekly if you don't get vaccinated.
Right.
I mean, we kind of
like
are of the feeling that we'd be happy if everybody was vaccinated, but where it is a personal choice and where we really don't want to lose any employees.
Yeah.
Right
no,
now,
we can't afford to lose any more employees right now.
Yeah. So we're hoping there's a little leeway maybe.
So as we go to press, we're not even sure that it affects ambulatory surgery centers specifically in those, and I'm talking about the 3 states that we've been monitoring today, but do keep a very close eye on what's going on in your state. Keep on top of the latest news.
Yep. And we have noticed some states are beginning to postpone elective surgeries again.
Yeah.
Now, I didn't put down particular states because it may be one hospital in a certain state, a couple hospitals. It's just kind of hit and miss right now. But it, depending on how things go, obviously we could be in that position again.
Yeah, sad. It's very sad that we're back there. Okay, well, let's take a short break and we'll come back. And in our focus segment, we're going to spend some time with our dear friend Daren Smith from SIS and talk about some technological things that have occurred. And actually, Sue, it ended up being, unfortunately, you couldn't join me for the interview, but it ended up being a very positive interview. It was kind of nice to talk about that not everything that came out of the pandemic was negative. I mean, I think we prefer to learn these things a different way, but certainly some of the changes that occurred and what we talk about in this interview with Daren were very exciting, I think, for the industry. So let's take a short break and we'll be right back.
When it comes to the financial outcomes of your ambulatory surgery center, it has never been more important to maximize revenue, tighten the time to bill and collect payment, and reduce denials from payers. Yet without a keen focus on your revenue cycle, it can be difficult to achieve the results your center needs to remain profitable. The revenue cycle experts at Surgical Information Systems can help. With revenue cycle services from SIS, you can improve the financial health and performance of your ASC. SIS Revenue Cycle Services takes care of all aspects of the revenue cycle, including compliant coding based on documentation, claim preparation and submission, claim management, accounts receivable management, billing follow-up, month-end reconciling and closing processes, standard and customized reporting, and patient portion due and/or balance management. By doing the heavy lifting, SIS Revenue Cycle Services leaves you to do what you do best: provide affordable, high-quality care. In addition to managing your revenue cycle, the SIS RCS team uses a 5-step process to monitor, analyze, and make recommendations for improvement to your revenue cycle performance. More than 50 ASCs enjoyed these results from SIS Revenue Cycle Services every month. Faster claim submission, shorter time to pay, improved AR follow-up, higher net collections, expert coding to meet exact payer requirements, and an overall more consistent revenue cycle. Visit sisfirst.com to learn how the revenue cycle experts at SIS can deliver improved financial health for your ASC. Again, that's sisfirst.com to learn more about SIS Revenue Cycle Services.
So I'm here with Daren Smith with Surgical Information Systems. Daren, it's always a pleasure to have you with us on the podcast. Today we're going to talk about a fascinating topic, kind of how things have changed as a result of the COVID-19 event, shall we say. And you wanted to speak a little bit about the kind of the technology side of it, what happened on the technology side, which, I mean, we know as a nation, suddenly Zoom is a new word out there, kind of like Kleenex, it's like the...
Right, it's a noun and a verb now.
That's right, exactly. Yeah. And of course, even though our audience doesn't know this, that's exactly what we're using to communicate with you. Even before this, we were using these like convoluted systems to connect with our guests on this show, including cell phones, and it was all very complicated. And today, it's just log on to a Zoom session. I sent you a link about an hour ago, and here we are all together with the latest technology. So why don't you just start out by kind of giving an overview of how things have impacted the technology side?
Sure. So as everybody knows, business has changed in the last year and a half. And from the technology side, what we are seeing is this is kind of the boost some people needed. This was the precipitating event that they needed to start looking at how can I operate more efficiently? How can I communicate with physicians and staff members and patients? And how can I do this from a remote location?
Right.
So how can my scheduler efficiently sit at home and schedule cases? So as bad as all of the lockdowns and all of the COVID restrictions that we had, it really forced people to look at their operations and see how technology could solve some of those problems they're having.
Absolutely. I mean, we've seen a huge shift in where people are working as part of the workforce. We just, as we're speaking today, we had a situation, here we are recording this in August of 2021. And we had a situation yesterday where in one of our centers, one of our staff people were there. And while they were there, one of the employees in the business office noticed that she had symptoms of COVID, did a rapid test, was positive. Unfortunately, the business office was not socially distancing nor wearing masks. So now the entire business office has been sent home, basically, and they're all going to go through rapid testing. And I mean, it really brings into question why, we brought them back because we thought it was going to be more efficient, but now we got 10 days without them in the office. And I'm certain the question is going to come up, should we just keep them at home in the future? If there is no ongoing problem, or maybe they only have to come in once a week. And your technology, I mean, we're not talking specifically about SIS here, but the technology of all those systems that are in the back office now has to adapt to that. So how do you think, I mean, I'm always curious as to whatever other people's observations are. Do you think this is permanent? Do you think that we are going to be seeing people really saying that in the future there are going to be a lot of functions such as scheduling, such as billing, such as coding, that can be done remotely?
We are seeing that, and we're seeing a lot more of the hybrid model. They want to keep a hybrid model because they still want to develop a culture and relationships and things like that. Mm-hmm. But if I only have to go to the office once a week, that appeals to a lot of different people, and it actually expands the group of people that I can hire.
Right.
Because now I have the ability to go outside of my city, township, or wherever I'm at and try to find the best talent instead of settling for who can get to the office in 30 minutes.
Well,
right?
And don't you also, it expands the time of day that they can be working? I mean, we want to make it convenient for us when we schedule patients, but there might be offices that want to schedule on a Saturday because their doctors are in on a Saturday, or, after what we would call hours, maybe, their scheduling department that, maybe those people are also working at different times, or the doctor is the one that does it himself, or the doctor looks at his schedule and wants to talk to the scheduler to see, what's going on. Don't you think that's another possibility there?
Yeah, that's part of that operational efficiencies that physicians and surgery centers are looking for. We always struggled as a surgery center that we had to contain our hours of scheduling just for financial purposes. And when the surgeon got called to the ER and wanted to see if there was room at the surgery center to do an open reduction of a fracture the next day, there was nowhere to go. Right. So, that's part of that operational efficiency too, where physicians are being asked to do more with less, and they want the ability to do just exactly what you said, pull it up on their phone. Mm-hmm. What does my schedule look like at the surgery center? Is there a place I can put this? Let me put in just a few data points, and that will send a message over to the administrator or the scheduler, whoever's covering that evening, that maybe this case can get at the surgery center, and I can get a more convenient location and a less expensive location for this patient to go, instead of racking them in the hospital, putting them at risk for COVID and all of those different protocols. I'm going to send them home, and then they can go to the surgery center tomorrow.
Right. And that is a trend that we have been seeing, certainly, is that the cases in many of our surgery centers are increasing, especially those surgery centers that used to share cases with the hospital. I mean, you're not finding huge increases in GI because most of them already moved over to the ASC. But orthopedics, I've seen a huge increase across the board in the cases that are moving over. And
that's what we're seeing too, is orthopedic, spine, and cardiology, right, that are trying to get those routine diagnostics out of the hospital.
Now, interesting as you mentioned cardiology, just about 2 hours ago, I was on the phone with a group of doctors who want to bring cardiology to the ASC. They've never even talked about it before. As a matter of fact, unfortunately, I don't know very much about it. I talk about it in the podcast that it's been added, but none of our clients up until now have done that. But what do you think from a technology standpoint, our ability to be able to do additional cases, where do you think some of those growth are? I mean, obviously orthopedics, but do you think cardiology is going to be one of those areas? Is that something that you're seeing in your daily life too?
Yeah, we're seeing that. We're seeing quite a bit of cardiology moving to that space. I think there's quite a few cases with the advancement of the technology for cardiac catheterization and other cardiac procedures. The more technologically advanced they are, the less risk we have. Mm-hmm. And so we're seeing the risk quotient for those patients going down to where they can be treated. And right now, when they go to the hospital, they're in and out in the same day.
Right.
So now we want to give them all the other benefits of going to a surgery center with the less cost, the more convenience, and all of those things. So
and the lack of risk of being in contact with a COVID-19 patient.
And that's just the bonus right there. Yeah. Is I don't have to sit in the waiting room that's commingled with all the other surgery patients.
What do you think about the technological changes? We've largely talked about the impact on the physicians and the surgery center, but how do you think this is going to impact the patient? And what options out there? I mean, obviously, your software provides some opportunities to communicate with the patient, but what other types of technological changes do you see that are patient-facing?
So we're seeing, well, of course, you saw the explosion of telemedicine with the pandemic. And so we're seeing a lot of routine care being pushed out to telemedicine. Mm-hmm. But even when it comes to telemedicine, we still have to document it and we still have to have a place to put it.
Yeah.
So that's where we as technological providers are being more involved with that. And we're not going to be everything to everybody. We have to make sure that the software that is created not only works for the one-room eye center, but also works for the 6-room cardiology and totals center.
Yeah.
So we have to figure out ways to be interoperable. And that's probably where we've seen a lot of that movement here in the last couple of years is, our expectation of a technology is you're not going to be able to do everything for me, but if you can't do everything, can you at least connect to the ones that do? Mm-hmm. We're never going to replace cardiac cath software.
Right.
We're never going to, do all the pressure measurements and do all the EKG views and ablations and things like that. But we need to be able to be in a position to accept that data when it comes to us and have a place where all of that data can come together.
I think that also can be said for GI too, because there's some great GI packages out there that do great documentation. You don't necessarily want to replace any EMR system, you want that system to interface with an EMR system will take care of all the other things like the pre-op and the post-op. What some of those GI systems do really best are the intraoperative documentation.
And their physicians are usually one of the bigger challenges you have when you start introducing technology. So if they are already accepting that technology and you're not going to tear it out of their cold, dead hands, you better be able to work with it.
So one of the things that's near and dear to my heart, and every week I run into this, and I know you run into it also as you're out there marketing, is the whole issue of packages that surgery centers have purchased that are not ASC specific. I run into this every day. Just ran into it a couple days ago with an EMR system that just isn't working right, and of course doesn't have some of the other advantages. How do you think that has changed? Has there been more of an understanding post-pandemic of the importance of moving away from, let's say, packages that have been designed for the office as opposed to, a physician's office, as opposed to something that's been designed specifically to ASCs? And while you're talking about it, let's kind of delineate why you need to have a package that's been designed for an ASC specifically.
Mm-hmm. We saw it a little bit pre-pandemic, and even 3 years ago, we saw more places trying to take their clinic system and smarten them up, or take a hospital system and dumb them down to fit in the parameters of the ASC. And we saw it slowly converting, and then the pandemic pushed it even further. That all those resources that would have been available from a hospital system or from a clinic system to work on creating more ASC specific things got allocated other places. So now the clinic is focused on telemedicine. So they've shifted all their resources from creating more ASC technology over to telemedicine technology. And same thing on the hospital side is how can we manage more ICUs and things like that instead of creating more ASC specific content. So that has boosted the need for the ASC content as well, or the ASC specific software. And we are still telling the same story we were 5 years ago, is we have a very unique way of billing. That is different than hospitals, different than clinics. And you need a system that understands that. We have state reporting. We are looking at things completely differently than any other division of healthcare. So you're always going to be trying to force that round peg in the square hole.
Well, and you bring up a very interesting point. Of course, I live in New York, and a lot of our clients are in New York. New York's not alone, though. There are other states that have state reporting requirements. But I have seen, and you and I have had some conversations in the last year about clients that have spent an enormous, we're not talking, we're talking six figures to fix the problem that they created for themselves when they did not select a system that was designed for an ASC that could handle the state reporting. And of course, they encountered salespeople out there that said, "Oh, don't worry, we can handle that."
Yeah, we hear lots of stories along those same lines that, oh yeah, we're right on the cusp of releasing more ASC specific or having a reporting module where you can create your own parameters.
Yeah.
Well, now you're dedicating your staff to do their job.
Well, and that's a very good point. I've seen that interesting sales pitch being made that they say, well, we don't have it yet, but you can get it. It's almost like you can get that for free because we'll work with you to develop that module. And that's exactly right. It's not really free because you're going to end up training them, and then you're going to have to put up with 6-12 months of development time. And by the way, we just had a situation, you and I think talked about it, where that completely failed. In other words, the vendor came back at the end of it and said, something, we can't do it. And here they were 9 months into the process with no solution, having to completely switch their software around.
Mm-hmm. Yeah, their eyes are bigger than their stomach sometimes, I think, where they think, oh, how hard can this be? It's a CPT code and a fee schedule, right?
Right. So let's just talk about telemedicine for a second, because it's not something that's obviously can be done in a surgery center. In other words, I'd love it if we could, do telemedicine. We could do that brain surgery or colonoscopy, from home, and you don't have to leave your living room to do it. But I don't think that's going to happen anytime soon.
No.
So how do you see telemedicine? I have my own opinion. I'm curious to see what you're thinking. How can telemedicine work in an ASC? What types of things can we be using it for in an ASC?
So we've always in the past had the opportunity to interact with our patients over the phone or over the internet, and sometimes that isn't quite as personable as a telemedicine or a video visit can be. So we have opportunities there for our patient engagement. But we also want to look at this as a way in which the physicians can interact with the patient's family. So if we have, in this day and age when, we have good old Delta variant sweeping through some of these states and we want to protect our physicians from exposure, maybe that's the best way to do it is, you sit in two separate rooms in the same building, but you're talking over video stream.
Yeah. We actually had a QI meeting yesterday where most of us we had 4 people in the conference room, 2 people upstairs in the surgery center. One was going in and out between patients, obviously, and then 3 people at home. And I'll tell you, the funny thing is I've been working with this organization for 7 years now. I've been doing QI meetings for 7 years. The first time we've done it in this weird way where we had people in all different locations, including people that could have come down into the conference room but chose not to, not just because of COVID, but also because it was just more convenient for them to be up there. And let's face it, part of the problem is, and frankly, I felt the same way, is I probably would have preferred to be in another room also so I could take my mask off, because it's very difficult. I'm getting older, can't hear squat. So I'm starting to realize, like as I'm listening to you, I'm watching your mouth. You forget how much you actually pick up for that. So I think that's definitely been, one of the big changes out there. I have so how about, let's talk about cybersecurity. This really didn't happen because of COVID, of course, but I think it exacerbated. Way too many people are sitting at home doing nothing except getting themselves into trouble. At least that's my opinion. So what do you think is going on there, and how should we be reacting to it? I think there are still a lot of people that are not taking it seriously.
Mm-hmm. And from our own perspective, as soon as COVID started to roll through internationally, we definitely saw a major uptick in just the threat and the number of people trying to invade systems, even our own. And you give people the time and the opportunity, they're going to try to get away with something.
Right.
And in a cloud-based environment, we can control it. Mm-hmm. When it's on a server in your closet, in your ASC, I can't control it. And that's what should be keeping administrators up at night. We've walked into surgery centers and they're still running, Windows ME and things like that, where, it's, we don't need any support. Yeah, we know that they don't support that anymore, but we haven't needed any support. Yeah. Well, it's more than that. That's also all those security patches. And as soon as you had to quarantine everybody had stay-at-home orders, you now created more pathways for them to get in there because your scheduler is remote, your coder is remote, your billing people are remote. So you've just opened up a whole new pathway for them to get in. So when everybody was working in the building and you only had a few extraneous visitors from the outside coming in, it was a much lower risk. But now that everybody's home and you had to create that remote desktop for 15 people over 3 people now, you've just given 15 more lanes of traffic for them to drive through. So that's what should keep them up at night. I'm not sure, that they have the visibility into that. But our security director has done a lot of interviews and articles and things like that to try to get people to realize the sheer magnitude of threats that are going on now and using those to get into those systems.
Yeah, and they're getting sneakier and sneakier. I mean, even I, who have a pretty heavy background in detecting these things, have, found a couple. I mean, I've never been caught yet. Knock on wood. Probably shouldn't say that. Now it's going to put somebody, challenge them. But I'm seeing these things where you kind of just have to sit back and say, hey, wait a minute. Yeah, this isn't right. And a lot of it comes through email. Now, that brings up another interesting thing. So as I'm sitting here right now, I spent 3 hours this morning reducing the number of outstanding emails from over 200, and I got it down to 30. Now, of course, in the time since I've been with you, I am sure it's back up to 200. Can we talk a little bit about how email is changing, how that is becoming less, I believe, of the standard for communication that it had been in the past, and what is replacing it? Especially with the technological tools that we have available to us in the ASC.
So we're in the process of that as well. I don't think we're ever going to be able to get rid of email. It's it's kind of like getting rid of landlines. We still haven't gotten rid of landlines at this point. So we're always going to have to service that part of the communication puzzle. But we are, and you'll see a lot of retail industry shifting this way as well. We're shifting into text. Yeah. And so we are seeing more ways to securely send texts and less opportunity for influence through text message than we are through the email, because everyone's wary of email now. And so often an email that comes from somewhere you're not expecting gets pushed off into a location that you may not be expecting it to be. Yeah. So we're shifting more towards that angle, and we're also shifting more towards electronic communication that does not require human intervention. Mm-hmm. So the ability to send information, not taking a spreadsheet and attaching it to an email, but sending those individual data points electronically through a secure connection. Mm-hmm. So, we used to, when I was running my surgery center, I would run my reports and I would send those via email to our accountants so they could do our end of month reporting. And, it's certainly a lot more secure and certainly a lot easier to put those in a format that just sends them electronically instead of attaching them to a public source like email.
Right. And for example, that's what we're doing within our company now, is that we have extranets with all of our clients where we're not sent. Well, and obviously it's all encrypted now. Everything is HIPAA secured, which means that as long as it's kept within those bounds, we are, there's a lot more security. And of course, being cloud-based, it does back it up. But so we've reduced the amount of email that is occurring back and forth when we're sharing data, increased the security of that data by not subjecting it to, public email, even with encryption. And I think that's greatly enhanced things. But of course, the problem that I'm running into, and that's the next thing I want to address, is the challenges that we have with getting our users technologically savvy. I find myself spending a lot of time explaining things that I barely understand myself because I'm old. And, and let's face it, it's harder for us as we get to this age to, really grasp things as quickly. At least maybe I'm speaking for myself. But I'm finding that challenge now, and it's really almost getting to the point where even within our own company, I'm going to have to hire somebody whose full-time job is to educating the users, not only our own employees, but our clients, as to how to use the wonderful technological tools that we have. Can you talk a little bit about that and how you're dealing with that challenge?
So we have some of those same challenges because people want to choose convenience over security.
Yeah.
Okay. And that's basically what it comes down to is, sure, I'd love to fill out this form that you sent me on my phone. I'm just going to grab Siri and do that. What they don't realize is Siri is not HIPAA compliant, and everything you say and it produces now belongs to Apple.
Yeah.
So it's getting them to realize that not all the time can we choose convenience over security. Yes, it is more involved and less convenient to do it the secure way, but I don't think they realize where some of that stuff goes. Using dictation when you're using Microsoft Word, which is fantastic. I use it all the time.
Yeah.
But if you're talking about patient names and conditions and medications and things like that, you just crossed a line I don't think you may have realized you just crossed.
Yeah.
So we try to educate them to use the tools as they were designed and continue to educate them as we go that, hey, we know this is a tool that's available to you, but it's not HIPAA compliant or it's not as secure as you think it is.
So, Daren, why don't we talk about, again, how we might be able to get those individuals. It is not just the people that are older, too. I've been picking on older people because I can do that since I am old. But as you start to use new tools, you do run into the challenge of trying to educate people how to use them. Do you have any suggestions? I'm sure there are many people out there that are just looking for some advice on how do we educate it. Are there people that we can hire? Are there websites you can go to? I mean, sometimes it's just learning how to use a basic tool, even Excel, which we all have to use. Even if we're using, an SIS software, you're going to have an Excel spreadsheet probably to pull together data that we're eventually going to put in there. What's your advice, if you have any on that?
Sure. So what we try to do is within the software you're using, try to make sure that they have some physical barriers to that as well. So a lot of times we can engineer out that risk. So we can block you from using Siri to do dictation if you're in our software, and we can block you from cutting and pasting from an outside source and things like that. So use the physical barriers that your software has available to you, but also I don't know if any surgery centers are doing this, if it's just software companies, but I have to go through training every month on how to prevent bad actors from getting into our files. And so my job depends on me taking these classes and passing these tests on cybersecurity and password security and physical environment security and all those things. So keeping it on top of mind, because sometimes I think people just forget about it and they get a little lapse where, God, this would just be so much faster if I could just use this app that I found.
Yeah, I think you're right. I mean, I think the key is education. And as an education company, the podcast, of course, probably is going to have to, kind kind of suck it up and come up with some solutions ourselves to be able to, get this out to the world, because I think it's long past time to start educating people. I don't know a great solution, because everything we've tried so far has fallen short of our goal of trying to be able to make everybody use it. One thing that we have found, especially working with software packaging, we're sometimes much more familiar with using for example, SIS or any of the other packages out there than our clients are, which is kind of disappointing to me, because I keep saying, well, didn't your software vendor give you that education? And I know darn well they did, but we know what happens is you get so overwhelmed with that training program, you pull in 25% of what you were taught about, and you don't bother to go back and take that additional training, which you need to have in order to follow up on it. But I think we really have got to start training people as much on using the technology as we are on training them to be good healthcare providers.
Mm-hmm. And that's something we're trying to engineer into everything we do. And the other technology, software and technology companies we work with are doing that as well. A tool we use is intra software help, so in the traditional scheme, if I didn't know how to do something, I had to go out and print a package of instructions together, and it had screenshots and things like that. Where we're trying to engineer out that variability is to make sure that we have training modules built within the program. So if I hire a new person, I don't have to stand over them and watch them go through this process 10 times. There is a software modality that will show them what boxes need to be filled in with what information. So we're trying to engineer out some of that, what we called it legacy training, where you never got official training. You just learned it from the person who was using it before. Yeah. And that brings forth good things, but it also brings forth bad things. So if you never get trained on how the program was designed to run, you may not be using it as it was designed or in the most efficient manner. Yeah,
right, exactly. I think that then you're just and you're also encouraging bad habits that might have been accumulated, from the prior individual with the new people, and I see that a lot. And sometimes they're just too, shall we say, cheap to go out and pay the extra money for the up-to-date training, whereas that training, that small amount of money that you would pay for that would pay huge dividends. I was having this conversation with somebody the other day that's saying, I got to come up with this system for tracking, my credential providers. And I've worked with your system and its predecessors for 30 years. And I believe that first system that I worked with had built-in credentialing oversight, and they had no clue that was built into the software package. And again, every major package out there that I know of that are designed for an ASC has that as a function. Mm-hmm.
And that's one of the things we encourage everyone to do as well is if you're not in contact, we put out enormous amounts of educational material and we have webinars and we have, videos that we send out and all those things. And if you aren't getting 2 or 3 emails a week from your software provider offering you opportunities to learn, then it's kind of on you then. Yeah. You're not taking advantage of what they're making available. And same thing goes on your side of the business as well, as if you're not educating yourself onto the new regulations and the new requirements, then if you are getting cited for those requirements, it's kind of on you because there's all kinds of people out there willing and able to help you.
That's right. That's exactly right. And we're a mature industry now. We have very, a lot of resources available to us that we never had before. When I started over 30 years ago, I was one of the only administrators in the state of New York. I had nobody that I knew how to, call. And of course, there's no such thing as the internet. Well, there might have been the internet at that point, but none of us knew how to use it or where to get it.
No, not to that capacity. Yeah, right. It's not like you could go out there and Google what's a fee schedule.
That's right. Exactly. I do want to go back to something we talked a little bit about before, but I think it's important is that the difference between, like client server and cloud-based, or shall we say in-house servers and cloud-based. You touched upon it by talking about how important it is for cybersecurity, but there really is another element to it is, cost and maintenance and, physical security as opposed to, just that cybersecurity side of it too. Do you want to talk a little bit about the advantages? I do suspect that many people might not even know what they have in-house. I find that a lot when I walk in. I say, do you have your own server here? And they'll say, I don't know. I have this, they'll point to a room and they'll think that all the stuff in there is a server, and it might not be. For example, it might be just the communication system. Talk a little bit about about how that industry is changing with that. Which, by the way, given that I've been around for a long time, seems like a circle, doesn't it?
It does.
In the beginning years of computers, that's how we did it, and then we went to individuals, and now we're back to shall we say the cloud. But go ahead and talk about that a little bit.
Well, and that's one of the key things that when we get in front of ASCs, that's one of the questions we ask them is how are you doing your backups? Because if there's going to be a ransomware attack, if your server's going to go down, if any of those never happen things on your in-house server happens, do you have a backup? And if they say yes, then we say, when's the last time you restored a backup? And the standard answer is, well, I don't know. I've been here 15 years. I've never had to.
Yeah.
And that's usually the indicator we get, and that little light bulb will go off on the top of their head that says, holy cow, I don't think I've done that for 4 or 5 years, restoring a backup. And we actually sat there and walked the surgery center through restoring a backup, and it didn't work. Yeah. They found out that the hard drive that they were taking home in their purse every night was corrupted.
Yeah.
So that is usually how we can put it on a personal level. Are you doing backups? Have you ever tried to restore a backup? And when's the last time you did that to make sure that A, you knew how to do it, and B, it was successful? So being in a cloud environment, we are constantly backing up. So not only are you writing on a primary stack of servers that are sitting in Texas, it's also concurrently writing on another stack of servers in that same data center on separate ends of that data center. But not only that, then we have a disaster recovery site that it's writing to as well. So we are providing you 3 different backup or use options that we have available to you. And we test that on a daily basis to make sure that we can restore a backup, that our backup is clean. So that should give you peace of mind that you're not going to lose everything that you have, or you're not going to be Googling what Bitcoin is so you can pay the ransom.
Well, and to that point, like we have that same situation. We use a cloud-based provider that actually backs up to all over the world in order to provide that. So we're pretty secure with it. But even with that, we still back up to actually, I'm sitting in the studio here. It backs up to a little computer over in the corner there. Well, it's a little computer, but it's got a really big hard drive that as soon as the backup is done, it's taken offline, and we do test that every week to make sure that that everything is there. But yeah, I mean, if you're not doing that, you absolutely should try it once. I was about 20 years ago, I had a hard disk failure in a surgery center. The surgery center that I was running at the time, before I started this company. And this is one of those scenarios where the software vendor or the hardware vendor promised us that this could never happen. Says that's the type of thing that will only happen once every 1,000 times. And of course, it happened to us. And it took us 2 weeks to restore it. And it was not pretty, and it was very expensive to do that. So hopefully that's one message everybody will get out of this, is start taking that seriously. Work with your hardware vendor as well as your software vendor to make sure that you're well protected.
And not even on the scary side of things, but on the operational efficiency side of things. When I have a new update that I have to security patch or a new feature or functionality, I have to go touch not only the server, but every single computer that is connected to that server.
Yeah.
In a cloud environment, we push out an update and everybody's on the same version at once.
Right.
And, the anesthesia workroom was locked and I couldn't get in there to update their computer. And now when they log in the morning, it's going to give them the database doesn't match the software version, and all of that goes away. So just that operational efficiency of I don't have to touch every computer and I don't have to go do the Windows 10 update on every single computer, and I don't have to do my feature and functionality updates. All of that is automatic. So, we usually try to compare it to, when you get that notification every week that Facebook wants to update, we're going to do the same thing.
That's right.
So we're going to plug those little holes that happen in software. There's bugs out there. You try to prevent every single bug, but those things happen. When you're talking about millions of lines of code, and a comma in the wrong place in a million lines of code can result in a bug. We need to be able to get in there and fix it quickly. And in a cloud environment, I can fix it within about 40 seconds for everyone who's on that environment.
Yeah.
When you're on a server environment, guess what? You got to touch every single computer.
Well, and of course, you're talking specifically about the vertical package, the package that runs your surgery center and the registration, billing, medical records, et cetera. But the same could be said for all of those files that we have to store. Traditionally, you would store it on an individual computer or on a server out there that everybody can see. But today, go cloud-based. Now, of course, we don't have a server per se like that in our company or at the podcast for that matter. Everything is cloud-based, and which is, as you said, constantly updated. The other nice thing about these cloud-based solutions is that if somebody were to encrypt our data on one of the machines, inevitably another machine is not going to be encrypted. And we also had the ability to go back in time to prior to whenever somebody encrypted it. So I'm not going to say it's totally impossible that we would have a problem, but it would not be necessarily with us. It would probably be with our cloud-based provider, which means, of course, you need to be very careful about who you use, when you choose those solutions. But don't think about it not only when you're looking at the software that runs your billing, registration, EMR, but also all those other things that we inevitably have to have a computer for.
Right. And making sure that if it is protected health information, that the company you're using understands what you're storing.
Right.
And that those things do need to have an extra layer of protection on them.
And that you have a business associate agreement with them.
Correct.
So in the 2022 proposal from CMS for the new payment mechanism and the Medicare quality reporting mechanism, one of the requirements is that OAS CAPS, which is a way of surveying our patients, is going to be implemented. It's effective in 2023. It's voluntary in 2022. Can you talk a little bit about how that's going to be integrated into your system, or predict how it's going to be integrated into some of these vertical packages? Because up until now, a lot of centers are doing their patient satisfaction surveys offline, like on a piece of paper. But as difficult as I think this transition is going to be, I do think that there are some efficiencies that we can get from it, albeit at a cost, because of course it's not going to be free to do it. But unfortunately, in this scenario, we have no choice. Medicare is going to require it. Do you have any observations on that?
Yep, we've been waiting for that. So that's
so have I.
We've been, because that process is not easy or inexpensive to create the methodology to get those out there, get the surveys out there, retrieve them, put them in the statistical analysis. And all of that has to take place away from your clinical record.
Yeah.
So it's not as easy as, I'll just create a new form in my clinical record that goes out to the patient, and then it comes back into the clinical record and it's not supposed to be there. So what our intention is if these things do get passed, that CAPS will be required, we will integrate that into our software. And our proposed version is it will sit outside of your business operations, and it will sit outside of your clinical operations itself. It'll be siloed in its own QA section of the software. So that's where all of that information will feed to. And the efficiencies that we see that we can provide is all that patient information doesn't need to go anywhere, because it's all using the same database to get out of the system and back into the system, but also we have very mature analytics programs where all of this information can get pumped in. So instead of looking at your statistical analysis in a graphical format from your AR or from room utilization, you're looking at the results of the patient satisfaction surveys. And then having also the internal wiring to be able to push that information out to wherever it's going to land for CMS. Yeah. I know there's been talk about that changing too, that it's a pretty antiquated system that they're using on the hospital side. So they've talked about updating that. So we talk about API connections, kind of the new version of HL7, and being able to just push that data directly into a bucket for CMS use would be much more efficient than the way they're proposing to do it now.
Well, and this is, as we've said to our listeners on the podcast, this is going to have a huge impact because you're not exempt from this if you're a small center. So, and there's just a base level of cost that's associated with it. If it's, as you said, if it's built into your software package that you use for billing and registration and EMR, there's a huge advantage, and that integration will save a great deal of time, maybe money, but time
effort, and money.
And of course, what I would be excited about, what you've just described, is the ability to pull that data and correlate it with other information that you have already existing in that database, probably to create some good QI studies that would be relevant. And of course, I'm skeptical that the OAS CAPS is going to give us a lot of great data, given the number of questions and the fact that we're not sure that patients are going to be very much interested in filling these things out or completing these conversations unless they're really angry with the surgery center. But nonetheless, I think we can gather information, and if we can correlate it using your analytics there into a way in our quality improvement meetings to be able to identify some changes, I think that could be a very big benefit here.
Right. Yeah. Looking at those patients and being able to correlate, okay, this group of patients was not very happy with one aspect of their care.
Yeah.
When you start correlating that to the EHR, did they spend an enormous amount of time in recovery? Did they have a particularly high acuity procedure? Did we screw up something on the billing side that made them angry? And no matter how good we were, they got a $2,000 bill in the mail when they were expecting a $200 bill, and they turned on us.
Yeah.
So having the ability to correlate all three of those silos, the clinical silo, the financial silo, and the quality silo together, it is exciting from an old administrator's perspective
and a statistician here. Yeah, I agree. I mean, I'm anxious to get that data. I'm just, but as we all know, that the information that we work with is only as good as that input that we got in the first place. So if all we got were we surveyed 100 patients and 99 of them were angry with us, it's probably not going to be as valuable as, or it might give some false impressions about the care that's being rendered. And I know that's what's been happening in the hospital CAPS version out there, is that it really very difficult to get useful information out of it.
Oh, and their return rates have been just horrible too.
Yeah.
It's just not, I think people are over surveyed.
Yeah.
I get a survey every time I take my dog to the groomer.
Yeah.
I mean, is his haircut? Great. I don't need a survey.
Well, I drive 60,000 miles a year in my car, so the car's in for the repair shop constantly, just, not for breaking down, but, tire changes, oil changes, brakes and things like that. And I used to fill them out, but, now that I get them weekly, it's just not worth it to me. Daren, my last question is going to be, kind of predicting the future. Is there anything that I've missed that you want to talk about that you want me to introduce?
I don't believe so. And we're trying to follow the same path that people saw in the acute care side. In the acute care side, it used to be a best of breed model, where you just go find the best OR system and the best inventory system, and they'll figure out how to make them talk together.
Yeah.
And when we look at the future, we've seen Cerner and Epic on the acute care side, and Meditech, those that do everything and put it all in one software package. That's, I think, where the focus is going to be, both from the vendor side and from the client side. So I think we're really going to see movement, especially in the next year, of consolidation. We want you to come to the SIS website, and we want you to be able to do everything from there. I don't want to make you go out to Blue Cross Blue Shield of Iowa, Iowa's website. And I don't want to make you go out to Waystar's website to do denial management. And I think looking forward, that's part of what we're going to see, is the consolidation of from best of breed to single vendor. Are you seeing that as well?
Yeah, exactly. I think, and not only in our industry, of course, but across the board, as people are trying to find, one solution that kind of covers everything. I mean, actually, with ambulatory healthcare strategies, that's what we're finding, is our clients are demanding so many more, or not so much demanding, but they're saying, hey, I got this other need here. And, we're stepping in and saying, oh, okay, guess that's something we're going to be doing now. We've shied away from, credentialing for a long time. And now, here we are, we're not a CVO, but we're doing an awful lot of the work for many of our clients just to help credential people. And, it's a strain on our resources, but people are willing to pay for that advantage if they don't have to hire additional clerical people in order to cover that in their organization. I think that's the point there, is that what we're trying to do is find some operational efficiency. If people haven't figured this out already, the labor market is not great right now. There's not a lot of people out there to do the work, and we got to keep the ones that we have very happy so they don't leave, which means that they need to have those resources. They need to continue that work, recognizing that those resources probably aren't going to be in the form of a lot more staff people.
I think we're going to I actually see the ASCs benefiting from this, because I think there's going to be a lot of healthcare workers getting out of acute care and looking for a different environment. And a lot of times ASCs can provide that. So hopefully that means great things for ASC staffing.
This has been a great conversation, Daren, because it's, I think that we've had so many conversations lately about how dire the situation is. And you put an interesting spin on it, and of course we all fall into that because it's been a tough year and a half. But it's been great to have a conversation about those positive things that have come out of this. And I really appreciate your time.
Thank you so much for having me, John.
In this segment, we discuss other learning opportunities in the ASC industry. If you would like your event to be included in the podcast, please send the event information to info@ascpodcast.com.
The California Ambulatory Surgery Association's 2021 annual meeting is September 8th through the 10th, 2021 at the Hyatt Regency Huntington Beach Resort and Spa in Huntington Beach, California. For more information, go to casurgery.org.
The Illinois Ambulatory Surgery Center Association's annual meeting is on September 22nd, 2021 at Sheraton Lisle Naperville Hotel in Lisle, Illinois.
The Ohio ASC Association's conference will be at the Hilton Columbus Polaris on September 27th and 28th, and they'll host on those days a 2-day event featuring an exhibit hall and 2 full days of education, and I have the privilege of being the keynote speaker.
The New York State Association of Ambulatory Surgery Centers live and in-person Roaring Twenties conference will be held at the Sleepy Hollow Hotel and Conference Center in Tarrytown, New York on September 29th and 30th. For more information, visit nysaasc.org.
And we have a very large presence there, so we're reporting a podcast from there. And I think we have 7 of our employees are coming out. So make sure if you're visiting to visit our booth. We're also going to have, I forgot to mention this under Ohio, but we'll have a booth in Ohio too. The Washington Ambulatory Surgery Center Association's annual education conference and trade show will be November 4th and 5th, 2021 at the Tulalip Resort and Spa in Tulalip, Washington.
I just love that word, Tulalip. I just have to visit sometime. So Pennsylvania Ambulatory Surgery Association's annual meeting is November 8th 2021 at the Hershey Lodge in Hershey, Pennsylvania.
And as we mentioned earlier, the ASC Director of Nursing Bootcamp, which was extremely popular in May, the November cohort will be presented by the ASC Podcast with John Goehle on November 16th through the 19th, presented, of course, virtually. For more information, visit ascpodcast.com. Well, that's it for this episode of the ASC Podcast with John Goehle. Join us again, and please consider becoming a patron by going to our website at ascpodcast.com and spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Kelritis, Amy Durbano, Lori Rodricks, and Ann Geyer. Music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, SIS. SIS's mission is to deliver solutions and services that help surgery providers, regardless of care setting, improve their organization so they can deliver the highest level of care to their patients. For more information, go to sisfirst.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.